A warm welcome to my colleagues and dear friends. This is Dr. Mehman Afzal Hussain from Hyderabad, India. Today in this video, I'll be discussing about the ovarian tumors. So, ovarian tumors can be classified into three main categories based on their potential for dividing and spreading. That is benign, borderline, and malignant. Benign ovarian tumors are non-cancerous growths that do not invade nearby tissues or spread to other parts of the body. Borderline ovarian tumors are also known as low malignant potential tumors that appear abnormal but do not show the invasive or aggressive characteristics of the malignant tumor. Malignant ovarian tumors, also known as the ovarian cancers, are cancerous growths that can invade nearby tissues and spread to other parts of the body. With a lifetime occurrence rate of 1 to 2%, ovarian cancers are the second most prevalent gynecological cancer after endometrial cancer. They are said to be having the highest mortality rate in comparison to other cancers. And the median age for diagnosis of ovarian cancer is said to be 63 years. Risk factors: the risk of developing ovarian cancer increases with age. Genetic factors also play a very important role. The patients with positive BRCA1 and BRCA2 mutation have 44% and 17% risk of developing ovarian cancer. A positive family history of ovarian or breast cancer and patients with hereditary non-polyposis colorectal cancer syndrome have a 10% risk of developing ovarian cancer in the future. Other factors that can contribute to the ovarian cancer risk include a higher number of lifetime ovulations, a low number of pregnancies, an early menarche or late menopause, and endometriosis. Coming to the types of ovarian tumors, they are classified into three primary tumors. They are epithelial tumors, germ cell tumors, and sex cord stromal tumors. Epithelial cell tumors are said to be arising from the surface epithelial cell lining of the ovary. They are further divided into mucinous and serous cis adenoma, endometrioid carcinoma, transitional or Brenner cell tumor. The malignant forms of mucinous and serous cis adenomas are known as mucinous cis adenocarcinoma and serous cis adenocarcinoma. A special feature of mucinous cis adenocarcinoma is known as pseudomyxoma peritoni that is seen on the imaging, which is nothing but the mucinous material collection in the peritoneal cavity. A special feature of serous cis adenocarcinoma are the formation of psammoma bodies that are visible under the microscope, which are nothing but plaques containing calcium and cellular debris. Other types of epithelial tumors include endometrioid tumors and transitional tumors. Endometrioid tumors develop from endometrial like cells that are ectopic in nature. They are benign cysts filled with dark blood, which is why they are also called as chocolate cysts. They can turn malignant and spread easily to fallopian tubes and the peritoneal cavity. Coming to Brenner's tumors, also known as transitional tumors, they develop from transitional cells that are usually found in the lining of the urinary bladder. They are solid tumors and rarely seen. I have uploaded a table on epithelial cell tumors, the types, the clinical features, the ultrasound appearance, and the histopathology features. Germ cell tumors develop from the germ cell that is responsible for converting into a mature egg cell. When these germ cells fail to convert into an egg cell and divide in an uncontrollable fashion, they lead to the formation of a germ cell tumor.
You must have read in embryology about the differentiation of the germ layers ectoderm, mesoderm, and the endoderm. Within these layers exists a special category of cells that do not differentiate, also known as the pluripotent cells. They usually remain latent in ovaries or testes and develop into eggs or sperm. In a few cases, these cells lose control over the division, leading to uncontrolled proliferation and ultimately resulting in the formation of a tumor.
Teratomas are germ cell tumors divided into mature cystic teratoma and immature teratoma. Mature cystic teratoma are most common ovarian tumors found in young women. One example of mature cystic teratoma is stroma ovary tumor that consists of thyroid tissue secreting higher levels of thyroid hormones leading to hyperthyroidism. Immature teratoma develop from neuroectodermal cells that are often malignant and metastasize quickly. The second type of germ cell tumor, known as a yolk sac tumor, most commonly found in children. They are said to be aggressive in nature. A special feature is the presence of shielded wall bodies seen under the microscope. These are nothing but the rings of cells around the central blood vessel. The third type of germ cell tumor, choriocarcinoma, they are usually smaller in size, have a tendency to bleed easily, they spread really quick, they consist of syncytiotrophoblastic cells that secrete high amounts of beta HCG, leading to formation of an ovarian cyst. This germinoma, the fourth type of germ cell tumor, form when the oocytes grow uncontrollably. They are the most common malignant ovarian tumor, seen under the microscope as central nuclei surrounded by clear cytoplasm. A table containing all the information about the germ cell tumors. Coming to the third category of ovarian tumors, the sex-cord stromal tumors. These tumors develop from unlimited proliferation of the follicular cells and the connective tissue. The follicles inside the ovary consist of an oocyte and a specialized set of cells that help with the follicular development. The cells are known as theca cells and the granulosa cells. Luteinizing hormone stimulates secretion of androgens in the theca cells. Follicle stimulating hormone stimulates conversion of androgen in the theca cells to estradiol in the granulosa cells by the action of aromatase enzyme. Granulosa theca cell tumor is a form of sex-cord stromal tumor. It is the most common malignant stromal tumor seen in middle-aged women. The tumor arises due to unlimited proliferation of the granulosa and the theca cells. There is overproduction of estradiol, and the patients present with symptoms of uterine bleeding, breast tenderness, and early puberty. A special feature of granulosa theca cell tumor is the formation of columnar bodies that are seen under the microscope. The second type of sex-cord stromal tumors are the fibromas. They develop from the fibroblast cells and are usually benign in nature. The fibroblast cells are released as a part of healing process when the eggs are released from the ovary, and uncontrolled proliferation of the fibroblast cells results in the formation of a fibroma. Patients with fibroma often complain of pulling sensation in the groin as the tumor compresses the round ligament. A few patients with fibroma also present as a part of Meek syndrome. Fibromas have an appearance of needle-like strands with nuclei under the microscope. The third type of sex-cord stromal tumor is the Sertoli Leydig cell tumor. The cells that undergo unlimited proliferation look like Sertoli Leydig cells that are usually found in men. The testosterone is excessively produced in this tumor, which is why the patients with this tumor usually present with masculine features like hirsutism and increased hair growth. A special feature of this tumor is the presence of rinky crystals under the microscope. Table with all the information on sex-cord stromal tumors. Clinical presentation. In the past, ovarian cancer was known as a silent killer as it often presented without any noticeable symptoms. Nowadays, early stage ovarian cancer is present with subacute symptoms like pelvic and abdominal discomfort, changes in urination patterns, bloating, early satiety, abnormal bleeding, and postmenopausal or rectal bleeding. Paraneoplastic syndromes like polyneuritis, cerebellar degeneration, dermatomyositis, and hemolytic anemia may also be present. Acute symptoms are more common in advanced stages of ovarian cancer, and immediate evaluation and treatment is necessary. Patient may also present with extrapelvic symptoms like ascites, malignant pleural effusion, bowel obstruction, or venous thromboembolism. Intrapelvic symptoms like ovarian torsion may also be observed. Signs of metastasis like omental caking, supraclavicular or inguinal lymphadenopathy, signs of liver metastasis like nausea, jaundice, and ascites, signs of CNS metastasis like headache, seizures, focal motor deficits may also be present. Coming to investigations, ultrasound is the first and the most important test. Both transabdominal and transvaginal methods are to be utilized. The ultrasound helps with the size, structure, laterality, mass, margins, and vascularity of the tumor. It also helps with differentiating between a benign and a malignant mass.
CT and MRI scans are usually not recommended, but can be done in special cases in determining the origin of pelvic masses, in determining the extent of ovarian metastasis, and assessing the feasibility of surgical resection.
Tumor markers, CA125 being an important one as it is found to be elevated in 80% of malignant epithelial ovarian tumors. We also have a list of tumor markers elevated in other tumors. Biopsy. Non-invasive biopsy is usually not recommended. Surgical evaluation is recommended only for cases with a higher probability of a malignant ovarian mass. Fine needle aspiration is absolutely contraindicated in ovarian tumors because the procedure might directly spread tumor cells to the peritoneum. Differential diagnosis, we have the gynecological causes and the non-gynecological causes. The staging of epithelial ovarian cancer is determined using the International Federation of Gynecology and Obstetrics and the tumor node metastasis classification system. Treatment. We have three options for the treatment of an ovarian cancer. They are surgery, chemotherapy, and radiotherapy. Surgery, it is an essential component of ovarian cancer treatment. The options include peritoneal cytology, hysterectomy with bilateral salpingo-oophorectomy, pelvic and para-aortic lymph node dissection, omentectomy, and surgical debulking.
Chemotherapy is the second option, usually indicated for early stage disease, high risk disease, for example, patients in stage 1C and 2, advanced stage disease, for example, patients in stage 3 and 4. Mode of administration is either intravenous or intraperitoneal. The preferred regimens include carboplatin, paclitaxel, 5-fluorouracil, oxaliplatin, and carboplatin, paclitaxel, bevacizumab. Targeted molecular therapy, it is not a treatment option but usually reserved as a maintenance therapy after surgical debulking and chemotherapy in cases with positive BRCA1 and BRCA2 mutation. The drugs used are poly-ADP ribose polymerase inhibitors such as olaparib, niraparib, and veliparib. The third choice of treatment, radiation therapy, is usually not preferred but can be used as symptomatic treatment for recurrent or metastatic disease.
For prognosis, we have the FIGO classification.
Coming to prevention, individuals with a high risk of developing ovarian cancer should undergo a familial risk assessment. They may receive genetic counseling and be recommended for genetic testing to determine the presence of hereditary cancer syndromes such as BRCA1, BRCA2, or Lynch syndrome. For cases with high risk mutations, they have two options. The first is risk reducing bilateral salpingo-oophorectomy. The second option is periodic screening for ovarian cancer, which involves annual transvaginal ultrasounds, pelvic exams, and CA125 level measurements. Thank you.